Welcome to Variations 4, the shock unit. In this video, we'll be covering questions 11 to 13. So 11, explain the rationale for these drugs used in MAP 7 and 8. So on MAP 7, you've got these vasopressors being used, mimicking the sympathetic response, and they cause this vasoconstriction. So you may need this in the case of someone who is in shock and they have that systemic vasodilation. We'd mentioned that, corticosteroids can also reverse or dampen the immune response, which is an inflammatory response, if that's what's causing the shock. But corticosteroids have their own issues too, and sometimes the preference is vasopressors, better outcomes. And so they cause vasoconstriction, and hopefully that vasoconstriction serves to, in the peripheral vasoconstriction serves to increase blood pressure to core organs. So the risk of that, so that's the idea of vasopressors. You've got this massive inflammatory response, vasodilation. You're giving a vasopressor to cause vasoconstriction to increase blood pressure and perfusion. The risk is that you can cause severe vasoconstriction. You can actually cause loss of extremities. Some people have had to have amputations because they've lost circulation to extremities during these emergency periods from the vasopressor. It's a risk. It's life over limb. Also, with vasopression, you're increasing your vascular resistance, and that can increase workload on the heart and cause damage to the heart or heart failure even. There's also the risk that the vasoconstriction could actually decrease perfusion, especially, as I said before, to extremities. So if possible, try to use IV fluids to boost up BP. But again, if you've got massive vasodilation, that might not help for very long. Other meds we have here. On the opposite side of things, flipping the gear here, vasodilator drugs, the opposite. So maybe you're in someone who's in a progressive state of shock and there's excessive constriction everywhere that's decreasing perfusion and increasing workload. So you give vasodilators to cause the exact opposite. Nitroglycerin is an example of one, which will cause vasodilation to drop the cardiac workload. So it's easier for the hearts, the afterload is lowered so they can get higher cardiac output. Of course, with vasodilators, you want to make sure that you're not lowering blood pressure too much. Okay, then specifically some meds for cardiogenic shock, and these should just be a real review here. You know what nitrates do. We've talked about nitroglycerin and how it lowers blood pressure. Diuretics, you know how those work to lower. Vasodilators, we already talked about. You know what beta blockers do in terms of decreasing heart rate and decreasing blood pressure. What do these all have in common? All those meds we just talked about decrease the workload of the heart, therefore could increase cardiac efficiency, thereby increasing cardiac output and perfusion. However, again, you have to make sure you're not dropping blood pressure too low. Otherwise, that won't help either. That perfusion will be decreased even further. So you got to monitor your patient and their vital signs before giving these. Then you've got your meds like inotropes that will increase the force of the contraction without decreasing the heart rate. So we know how DIG works. It's not an inotrope. A DIG is something that, for example, will decrease heart rate as well as increase the force of contractions. You may want to use something that will increase the force of a contraction without decreasing the heart rate. That would be something like dobutamine. All right, question 12, 2 goals in treating hypovolemic shock. Well, without even looking at the maps, what do you think they are? This is really straightforward stuff. hypovolemic shock. So that's someone who's like bleeding or someone who's dehydrated. So goal number one would be stop the problem, the causing problem. So if they're still bleeding, stop the bleeding. Put pressure on that, cauterize it, take them to surgery, but you got to stop the bleeding. And then the second part, of course, is fluid resuscitation. Maybe you get away with IV fluids. Maybe you need a blood transfusion. Question 13 here, explain the rationale for these three things: blood sugars, white blood cells, and temperature in severe sepsis. Interestingly enough, one thing these all have in common is sugars could be high or low in sepsis. Early on, sugars could be high because of the stress response. Later on, they could be low because you run out of glycogen stores. That's assuming we don't, replenish them, assuming we don't give the patient anything. White blood cells can be incredibly high because, after all, sepsis is infection that activates the immune response. However, they could also be really low because the infectious agent can get into the bone marrow and depress the formation of white blood cells. So for sepsis, you actually look at whether it's high or low. It could be either one. And temperature as well, again, could be high or low. The invading organism can mess around with the hypothalamus, causing raises in temperature or decreases in temperature.